you can actually chat directly with the dedicated person or with the entire group.
Sir, I think it is 6 o'clock and
we are going live now, sir.
We are going to live.
Sunil, 1,
Yes,
2,
sir.
3.
Yes.
Can we start, sir?
Yes, sir, we will.
Time ho
Prasad,
gaya?
are we ready?
One.
We are all ready.
Done.
एक ही मिनट
Okay.
में कर रहा हूँ सर. I'll share good to go. Then we'll live.
Okay. Okay.
Fine.
And you can mute others, please.
नेक्स्ट लगा पहली वाली तो पता है मुझे अभी रुक जाओ feeling like a news anchor, you know, where you can't see the audience and you're just looking at a screen.
Sir, you are live now.
Namaskar. Can I have the first slide, please? Namaskar, I am Dr. Sunil Jindal here, and we have this first meeting which we have of the Global ART Forum. And of the Global ART Forum. And we'll be here for about 1.5 hours, and I'll be the moderator for the panel. And we have a very, very illustrious panel today. But I would like to introduce myself first, yours truly. The first slide, please, sir. I am Dr. Sunil Jindal, a father of 3 children and husband to a wonderful wife. I'm a surgeon and urologist by training, an ART specialist and andrologist by passion. I love life and human beings, and that's the reason I'm here today. And it's fantastic, and really appreciate all of you for joining us on this program. And the best thing is you're doing it really to add value to human beings. Next slide, please. I'd like to share a story of my life with you. It was 1st of March, 1991. And that was the day when, I remember it was an afternoon. I was with my grandmother. My grandmother had very severe angina. And she was a diabetic. We were really wondering what would happen. And the second she had she had to get an angioplasty done. I was sitting with her. I used to love her a lot. And I looked at her and asked, what will happen tomorrow? She said something beautiful. She said, the storm would pass away, but the dreams would always remain. Next day, we lost her during an angioplasty, but this remains with me always. And this is the reason where, like all of us, storms pass by in everybody's life, but dreams remain. We decided this was the biggest storm of the whole universe, which was COVID. And why not open the next slide, please, sir? I'd like to have a slideshow, Dr. Agarwal, please. Yeah. And therefore we decided, the previous one, please. Previous one. Therefore we decided to have the Global ART Forum with a mission of a free, not-for-profit, non-political platform which shares the latest knowledge embedded in science and facts with reproductive professionals, empowering them in turn to take good care of their patients, with a vision of a collaborative live educational forum of medical experts for reproductive professionals that assist them in the path of continuous learning and excellence. In fact, कुछ चीज हिंदी में कहना चाहूंगा क्योंकि वाकई में बड़ा खूबसूरत ये पूरी की पूरी चीज है जो आपसे कहूंगा कि कुछ सिखाकर यह दौर भी गुजर जाएगा, कुछ सिखाकर यह दौर भी गुजर जाएगा, फिर एक बार हर इंसान मुस्कुराएगा, मायूस ना हो मेरे दोस्त इस बुरे वक्त से, कल आज है, आज कल हो जाएगा. Next slide, please. Next slide, please. I would like to share the timeline which is there, and the timeline of the COVID is that China reported the cases of the first cluster on 31st of December. It announced the first death on 11th of January. China locked down Wuhan, and if we remembered, we thought only China could lock down a city. Scientists estimated on 27th January how quickly the virus spreads, and that was the day it was understood that quarantine and lockdown is the only way out. The first human transmission took place in Thailand in 28th of January. WHO declared on 30th of January it as a global health emergency, and that was the day that the first case of COVID was found in Kerala. Next slide, please. It's unfortunate, but the person who was the whistleblower died on 7th of February. China revealed that 1716 health workers were affected and 6 died. New cases came to light in India on the 4th of March. Corona outbreak was called a pandemic on the 11th of March, and our Prime Minister announced a 21-day lockdown on 24th of March. 2 incidents which have changed the whole history. One has been the Tablighi Jamaat religious congregation, and today it has been extended, and the extension has been further by the Prime Minister till the 3rd of May. Next slide, please. This is the way the whole world today is, and I have brought this slide only for us to understand a few things. Number 1, USA has 678,000 cases of the total cases, while India today has 13,495. The total number of deaths in the United States, which is the maximum in the world, is 34,641. In India till date and till time are 448 deaths. The total number of patients who, if you ask me, the maximum number of patients, the per million population, total cases per million population, maximum is in Spain, which is 3,956. And in India, there are 10. And the total number of deaths maximum are in Spain, 413, while in our country it's 0.3%. But we need to keep into concentration and in our minds one small thing, that the testing rate of our country is one of the lowest in the world. Next slide, please. You can see the graph. The graph shows us one thing clearly, that still it's a rising trend, but from the time of lockdown, there has been no spike, which makes us to understand that the spike is not there only because of the lockdown. If the lockdown opens, we really do not know what exactly may happen, but we may have the kind of spike which we have initially. Next slide, please. Now, if we look at the total number of cases, somehow this dashboard is showing different from the previous dashboard. It's 11,201 with 437 deaths, and 1 case over here is migrated. So this is the present status in our country. Next slide, please. So I'm here to moderate the panel of one of the most illustrious people which we could have here. We have Dr. Ashok Agrawal from Cleveland Clinic, Ohio, USA. Dr. Blockeel, who is the medical director of the Center of Reproductive Medicine of the University of Brussels, Belgium. Dr. Hrishikesh Pai, whom we all know very well, has been the Secretary General of FOGSI, and in fact, in every organization of the country, he's always had a very active role. Dr. Prakash Trivedi, I always fail to understand how to introduce him as a laparoscopic surgeon, as a urogynecologist, as a hysteroscopic surgeon, as an ART specialist. He has been on the forefront in all of them. He has been the FOXI president in 2015 and presently is the president of Isar. Dr. Sudha Prasad, who is at the moment the president of the Indian Fertility Society, whom she is representing, has been the director professor in Maulana Azad Medical College and a very eminent teacher. Dr. Nandita Pal Shetkar, whom all of us know so well, who was the immediate past president of FOXI and is the vice president of Isar 2020. Dr. Pankaj Talwar, who of course is a brilliant academician and was in the army and is a Vishish Seva medal, has received a Vishish Seva medal. So we are here at this juncture with all the eminent panelists. Next slide, please. And we would just open up the panel now with Dr. Pankaj Talwar. The next slide, please. Dr. Pankaj Talwar is a brilliant academician, has written a lot of books, is on the editorial board of multiple infertility journals, is the founder secretary of Fertility Preservation Society of India, and at the moment is the senior vice president of Indian Fertility Society. The stage is for you, sir, or the screen. I do not really wonder what to say, but at the moment, this screen is yours, sir.
Namaskar. Today, we talk about a disease which has brought down all of us from tight hugs to namaste. Before we move to how this pandemic is causing devastating effect on all our lives and everybody, we talk about the policies and the guidelines. I would like to talk to you all about the basic virology. What is a virus? How does it work? How does it replicate? And how does it affect all of us? Second slide, please. So we would have seen this picture multiple number of times on the internet. We would have seen it in blogs every day. On the left side, you can see a small spherical ball-like structure, which has got a large number of projections. And these are called actually papillomates. This is a cartoon picture. And you can find that the gray thing is what we call as an envelope of the virus. And on the top, we've got various proteins. They are here, we are seeing them in three colors. We see a yellow protein, we can see something pink and something bright. It's a purple magenta color. So what happens in the body? How an innate organism, which have no life of its own, it enters the body and starts multiplying and growing. On the right side, in the picture, we can see that a small virus particle probably enters the body, multiplies n number of times, and then starts transmitting and has brought the whole world to its knees. Next, please. Next slide, please. So before we move further, let's talk about the small particle which is called a virus. What is a virus? It's amazing to know that it is a non-living particle. It's got no life in its own. It cannot survive on its own. And it's always need somebody's body, somebody's organs to invade and then multiply. It is called non-living because it cannot exist purely by itself. It will always require some sort of a host to enter, penetrate, replicate, make it multiple carbon copies, which we call them as progenies, and then transmit. It is non-cellular and it is referred to as a particle, in fact, a non-living particle. The size varies from 20 to 300 nanometer. It is called a virus when it is outside the body, and when it comes in its infectious state, it is called a viron. There's a nice picture on the right side of the screen. It's an electron microscopic picture. You can see a round circular thing on which we find small papillomares going all around it. These are the proteins which come from the envelope. Down below is a very nice picture which explains the whole morphology of the virus. And as you can see, again, a round spherical thing, the orange thing which you see here is the envelope. The green thing are the proteins. They are called the spike proteins. Then it's got an E proteins, H and D factors, and then M proteins. Inside the virus, you'll find the RNA. RNA can be seen, and it has got a positive sense RNA. Next slide, please. Now coming to, again, a cartoon picture, depiction of a structure of a virus. And if you focus on this picture, you'll find that every virus has got this sort of a pattern, but the shape may be different. What you see here is a virus which has got an envelope. This envelope is always of bilipid membranes. On the membrane, you'll always have some sort of proteins. They are called normally peplomers, and they are the ones by which the invasion occurs and the virus is able to enter the body. The proteins can be of multiple types, and nearly every virus has got different type of proteins which can bind to the host and then start invading and multiplying. Inside the envelope, you'll find that we've got a thing called nucleocapsid. Nucleocapsid is a glycoprotein layer which contains the genetic material, which can be either RNA or DNA. So coming to a bit of theory of the virus structure, as I've told you, we have a nucleic acid, we have a capsid, and we have an envelope. The nucleic acid of the virus is found within the capsomere or the capsid, as we have just spoken about, and it contains all the information for the virus to enter a cell, multiply, replicate, and then start transmitting. The capsid is a layer which will give shelter to the genetic material of the virus inside the virus particle, and outside we have a glycoprotein envelope. Next, please. So coming to the coronavirus structure, how does it look like, and what makes it a deadly virus, which has brought all of us together today to talk about it? It is an envelope virus. We just spoke about it, and it has got a positive sense single-stranded RNA genome, and it has got a nucleocapsid of a helical symmetry. The genetic material is so small, barely 25 to 26 or 32 kilobases, but it's one of the largest among all RNA viruses. It has got club-shaped spikes on the surface of the envelope, which in the electron microscope creates an image reminiscent of the solar corona. So we call it a coronavirus. The diameter of the virus in all is around 80 plus 20 nanometer, around 100 nanometer. Next slide, please. So how does it enter the body, replicate, and transmit? This is very important for us to understand that this virus will start infecting when the viral spikes or the proteins on the envelope, they attach with the complementary host cellular membrane. About coronavirus, it's very well known that the S protein on the virus, the spike protein on the virus envelope, will attach with the receptor, and in this particular case, the receptor is ACE2 receptors. As far as we know, the human gametes and the embryos don't have ACE2 receptors, but recently we are finding some scanty reports coming that may be present there. Next slide, please. So how does it replicate and transmit? There are primarily few 5 or 6 steps. And in case you look here on the left side of the screen, it will attach. After attaching, it will enter the cell or any host organ. Then it will have genomic replication and protein synthesis. After it has been done, it will again combine everything, form a new progeny. It is assembled again, and then it is released from the body or the cell, and it starts transmitting to the other people by multiple routes. In short, I'll bring you to this image on the right side of the screen. You'll find a coronavirus which has got a single-stranded positive sense RNA and spike proteins on the top. It'll come and attach with the receptor on the cell membrane of the host. These receptors here, in our case, would be ACE2 receptors. So binding and viral entry by the membrane fusion or endocytosis would occur. There are multiple pathways. And after it enters, the virus will open up. It will take the help of ribosomes and it will take help of viral polymerase proteins and it will go into RNA replication. From positive sense RNA, it will form a negative sense RNA. And from negative sense, it will again start making multiple copies of the positive sense RNA. When RNA is being replicated, on the other side, we'll have replication of S, E, and M proteins. And along with that, the nucleocapsid also starts forming. And these things are occurring, the translation of the viral proteins are occurring in endoplasmic reticulum. After all things have been done, we have multiple copies of the positive sense RNA coming. We have nucleocapsid being formed, and we have these proteins S, M, N coming together. They all join up again. It's a beauty how it replicates. From a dead particle, it wakes up again, make multiple copies, and it finally matures inside the Golgi apparatus, the intermediate compartment. And then it goes out to the process of exocytosis. It entered the body by endocytosis. A dead innate particle, it entered the body, and within no time, it forms millions of copies of itself and goes out by exocytosis. That's called the release phenomena. And then it takes over and starts infecting everybody around. Next slide, please. Thank you. I've ended, sir.
Thank you very much, Dr. Talwar. We finally knew that this virus, which is there, is something which actually is non-living. And the second thing is that the problem with these viruses is that they are very, very cunning. And this is supposed to be one of the most cunning viruses ever. The next person who is there is Dr. Christopher Blockeel. He is a very eminent scientist. He, in fact, is the medical director of the Centre of Reproductive Medicine, University Hospital, Brussels, and is also the president of the Belgian Society of Reproductive Medicine. Sir, we would like to know about the ESHRE guidelines and the way they have formulated. What are the guidelines for all of us? On to you, sir.
Thank you, colleague, and thank you everybody to give me the opportunity to talk with you about the ESHRE guidelines. Next slide, please. So, of course, as we are, next slide. So if we, from ESHRE, of course, we are looking on a daily basis at the website of ESHRE and ASRM. I think the next speaker will deal with the ASRM guidelines, but of course every society is looking at each other. But anyway, with regard to ESHRE, the first precautionary measure came on the 14th of March. So you need to know that when we are talking about the first case, which occurred in Wuhan on the 31st of December, so only a couple of months later, there was this first precautionary measure of the ESHRE society, dealing with the fact actually that people, whether or not they met the diagnostic criteria for the COVID-19 infection, should avoid becoming pregnant at this time. We are 1 month later now, and still whether there is a vertical transmission or not is still very doubtful. You know that the Chinese study that came out showing vertical transmission are maybe not completely reliable. So we are still looking around and trying to find evidence to know whether there is vertical transmission, yes or no. Then 5 days later, there was this second statement, and actually this was the big statement of ESHRE on pregnancy and infertility treatment and conception. And then there was the updated statement that came 2 weeks later, namely 2 weeks ago on the 2nd of April. Next slide, please. So if I could summarize the ESHRE statement on pregnancy and conception, then it is strongly advised not to start any treatment. So it means that people who are or were in the meantime under treatment could continue their ART treatment, but it was a contraindication to start a new treatment for IVF or ICSI. And actually, to avoid complications from ART treatment and pregnancy. Secondly, to avoid potential COVID-19 related complications during pregnancy, because we start to know that, especially in the third trimester, there might be complications such as preeclampsia and so on, what we are all aware of, given the new publications that are coming out the last couple of weeks. Also, to mitigate the unknown risk of vertical transmission, we already dealt with that, and then to support the necessary reallocation of healthcare resources. You know that I personally work in a big center with 5,000 cycles per year with 180 personnel members. Well, 80% of those people are now working in the intensive care unit, in the emergency department, and also on the ward, on the COVID and non-COVID units. So we really need the people on the so-called COVID floor. Then another reason was to observe the current recommendations of social distancing. So of course there is always exceptions, as we are all aware. So first of all, it was the people who are still under treatment, and secondly, for oncological reasons. So the oncofertility unit can continue working if it is for reasons for preservation of oocytes or embryos. So actually no fresh embryo transfer can be foreseen. This was the recommendation of ESHRE. Then with regard to the healthcare professionals and clinics, well, they should remain available, of course, to provide supportive care, psychological support, and clinical advice to their patients, preferably via an online consultation. So we have been starting with teleconsultations, and we are looking for also safe ways to get contact with our patients. They really appreciate when we talk to them via telephone consultation. There is also cameras that have been installed so that we can do this in a proper way. Next slide, please. Also important to know is that recently an ESHRE COVID-19 working group has been established with Anna Vega, for example, as a coordinator, Kersti Lundin, and other people involved in the ESHRE community, and they will give us updates on ESHRE guidance. They will give us substance for quick and accurate responses to questions that we professionals have, but also patients, and they are also available to answer press questions. So actually, now that the lockdown is getting in its final stages, you need to know that in Europe already Spain has is working on a so-called exit of the lockdown. In France, the lockdown ends probably on the 11th of May. In Belgium, it will be the 3rd of May. But the big question, of course, remains, what is going to happen after stopping the lockdown? Everybody to the hospital, or will it occur in phases? Who can we prioritize? Should it be the 40 age plus? Should it be patients with low ovarian reserve? Should we work with other tools to prioritize people to come into the clinic? Probably it will be this, that we are gradually increasing the possibility of having non-emergent cases, non-emergent consultations, and then starting the oocyte retrievals. Whether we will be starting with a fresh transfer with insemination procedure, that still remains an open question. So we do not know when we will restart. And this was it. Thank you so much. Next slide, please. Thank you so much.
Next slide, please, sir. And now I'd like to welcome Dr. Ashok Agrawal, who actually needs no introduction, because apart from being a brilliant scientist, he is not only at the moment heading the American Center of Reproductive Medicine at Cleveland Clinic, Ohio. He's also a professor of urology at the Lerner College of Medicine at the Case Western University. Apart from that, he is a brilliant academician who has been ranked by Scopus as the #1 author in the world in the field of male infertility, andrology, and human assisted reproduction, and is currently the editor of more than 40 medical textbooks, manuals. Dr. Ashok, the stage is yours. We'd really like to know what the ASRM says that the way it should be followed. Dr. Ashok Agrawal.
Ashok, you have to unmute Ashok, unmute.
The technician, please unmute Dr. Ashok Agrawal.
हो गया. Let me come back to my presentation. Just a second. Sorry. Can everyone see me and hear from me? Hello?
Yes, it's very clear.
Yes, we can see you.
Yes, we can.
Okay.
Yes.
Sorry about the technical snafu. I'm trying to learn about Zoom. As many of you, I'm not as good as Dr. Sunil, who's a master of all trade. So again, good evening from Cleveland here in USA. We are about 9 o'clock in the morning here. And it is yesterday we had almost 4 or 5 inches of snow, so it was really cold. So we are still having a cold spell in between, with some days which turns out to be nice and sunny. But the weather mostly for the month of April will remain colder. So I want to thank everyone who's there in the panel. And I want to thank all the delegates who are attending our session. So I want to discuss about, after Dr. Christoph Blockeel's presentation about the guidelines from the European Society for Human Reproduction and Embryology, the guidelines that were introduced by the American Society for Reproductive Medicine. I'm not the one who made these guidelines, but I will be trying to explain or summarize these guidelines, which have been made available by the society to its membership all over the world. And they are available on the website of the ASRM called ASRM.org. So you can actually see the detailed guidelines and various updates that are being sent every few days. So the ASRM formed its COVID-19 task force. And this was done for patient management and clinical recommendation during the coronavirus pandemic. And the recommendation in this document were guided by COVID-19 very heavy increase in terms of the incidence and the impact of the virus on patient health and fertility care provider, and the known and unknown impact of coronavirus on fertility, pregnancy, and transmission pattern. So let us visit, before we go to the ASRM, these are the statistics about COVID-19 footprints in the United States. We have a dubious distinction of having the largest number of cases in this country, which is really a very sad news. This data is from April 15, like 2 days before. These numbers have already grown, and you have seen these fresh number from Dr. Sunil's slide. So the number of deaths or the mortality rate is very high. It has gone up in 30s, and they are estimating by the latest model that if the social distancing and all other common precautions and the lockdown continues, that by August, the death rate may be in the sometimes in 60,000, which is a huge number of cases, but it is unusual times around this time in the world. And these are horrible things that we are seeing. In the state of Ohio, which is where Cleveland lies, as of April 14, we had over 7,000 confirmed cases, which have been increasing. And the total hospitalization was about 2,000, with the ICU admission about 654. And you can see half of these have actually passed away. So the mortality with this virus really is very high. And what we are learning, and you are all listening to it, is if a person has certain kind of comorbid conditions, some risk factors, then their chances of surviving once they actually go into ICU or go onto the ventilator is less than 30 or 40%. So almost they are saying between 50 to 80% of the people who go on the ventilator will not survive. So it is extremely scary. We have been working in the institution, but also some of us were given the chance to work from home and continue our work. So let us discuss the key recommendation by the American Society for Reproductive Medicine. And these are not very different than what we heard from Dr. Christopher. So again, suspend the initiation of new treatment cycles, cancel all embryo transfer, whether fresh or frozen, take care of the patient who are currently already in cycle and require urgent stimulation and cryopreservation, suspend all elective surgeries and non-urgent diagnostic procedures, and minimize any kind of personal interaction and increase the utilization of telehealth. So a lot of people who had no concept of Zoom or these types of video calls are learning very quickly about the virtual way of contacting and talking to the patient and trying to reach them and discussing about their condition. In terms of the risk mitigation and social distancing, when there is an urgent procedure, minimize the time the patient is waiting in the reception or waiting room. Of course, the use of telehealth for maintaining a contact with your patients, and comply with all your health authority recommendations. In terms of continuation of care, should be considered and individualized for patients who have already initiated the medication. And certainly that probably has already been done in some of the cases in the early part of the lockdown. Treatment should be limited to single cycle. These things are not so relevant now, because since we are now almost several weeks or almost 5 weeks or 6 weeks into the lockdown in some places, patients who were planning to proceed with oocyte retrieval should be counseled. We should also counsel the patients on the fact that risk of infection for pregnant women who develop COVID-19 are still unknown. This is very important. The data, especially from China, is coming in, and they are trying to publish a lot of scientific studies. And I think we are all learning in real time many of the data that is coming in and being published in Western journal. But still, that information is new. in terms of management of laboratories, IVF labs and andrology, um, the patient samples that are coming, they should all be considered as infected, whether they are from the patients who have an infection or not. Universal precautions should be used because that is really irrelevant whether they are from COVID-19 or whether they are from HIV or hepatitis. All surfaces should be decontaminated. Tissue storage is an area where it is very much recommended that the patient samples from coronavirus should be tested and kept sequestered in separate tanks considered as infectious. So all in all, I think if you look at the guidelines from the American Society for Reproductive Medicine, which is continuously updating and informing its member. I receive virtually every 2 days or every day some kind of notification from the society. So they are very active, just like many other societies, in trying to update its member, providing them the best science and information that they can. But the truth of the matter is that we really don't know a whole lot of things about this virus. And I think until unless there is an effective way to screen the patient by testing a large number of people, because a lot of virus transmission is occurring in asymptomatic patients as well, and following all the guidelines, for example, of social distancing, as well as taking proper precautions, we are not going to be able to open the hospital or the clinical practice at the end of the lockdown. It will be a very gradual, careful way that the practices can be opened, and it will be a new world. So we are going to ponder upon it later on. But I want to thank you all again for listening to me. Thank you, Sunil. I'm done.
Thank you very much, Dr. Agrawal. It really was enlightening, and you'll be very happy to know that we have 922 people joined in. It started with 633, now we are 922. So people are not leaving, people are joining in, which is fantastic. And Dr. Agrawal, you were sharing with me that there is a new study which is there to be published from Wuhan in fertility sterility, which you probably told me you will tell us at the end, something like
Yes.
that.
Yeah, I just thank you very much, Sunil. I think yesterday I got hands on a new article, which is in a preprint of a publication coming out in Fertility and Sterility. And I read through it in the night and made few slides. So I want to keep it towards the end, so that will be the way that we can keep everybody listening to all our speakers, and we will share that information at the very end. So thank you very much. Yes, I have that slides.
And now, of course, we have who else but Dr. Prakash Trivedi, who is at the moment the president of Isar, has been the president of FOXI in 2015, is the president of IAG, was the president of IAG in 2013. He is a pioneer hysteroscopic laparoscopic surgeon and ART specialist. Dr. Trivedi, the screen is yours. Would love to listen about the way Isar has planned everything in the future. Dr. Trivedi, please.
Dr. Trivedi, please unmute.
Thank you very much, Sunil. Dr. Agarwal, I hope you can hear me.
Yes.
Yeah. It's an important day when ASRM, ESHRE, Isar, IFS, then intellectual friends are interacting on this issue. Can I have the first slide, the next one? Now it's very interesting, I became the president of Isar on 6th March, and everything was fine till we get back, and then 11th, 12th March onwards, everything started, to concise. And sometimes I truly feel that my theme of the year was advanced infertility management at the doorsteps. And I, in fact, told that people should be more with patients, should remain at home rather than conferencing. But I didn't mean that we should be locked down. And in COVID, we have the first phase, which is the phase of fear. Now we all are in the learning phase. We'll enter into the green zone, and then we'll have the staggered unlockdown. In India, the situation is different because we have 40,000 gynecologists and 3 to 4,000 ART centers. And we were fortunate because we had a lockdown from 23rd of March, when the number of cases were roughly 1,000 or 1,200. Next slide. Uh, because the structure and culture of India is totally different. It is highly social. People move around, streets are flooded, people go to work, nobody wants to stop working. And it's a commendable job that our Prime Minister could bring a lockdown in such situation, such an effective fashion, and also added. This obviously made things a little bit easy for the ART practitioner in Isar and IFS, because in general we didn't have a typical infertility consulting. And unlike Europe and America, a lot of ART practitioners in India do endoscopy. There are lots who also have obstetrics and other things. So there is, if something gets positive in an institute, all the services gets locked down. Social distancing was an issue, but implementation was good, and people learned how to remain at home and work from home. In fact, we all started getting used to how to view life in a different perspective. Though the sperm, according to JAMA, may not have the virus, but IUI, IVF treatment were stopped. Only those which were ongoing, again there it was like a pickup is done and all the embryos are frozen, and nothing was done to avoid the possible complications in general about ART. Or suppose if they become pregnant during this phase, and there's a lot of concern about virus causing morbidity to the pregnant mother. Obviously, vertical transmission till recently, wherein there's some demonstration, but as Christopher rightly mentioned, of the 48 patients which delivered in China, there was no vertical transmission which was noted. A lot of hospitals have to reallocate their healthcare, which means that an ART center or a hospital, whether in Mumbai or in Delhi, may be asked to give the beds for COVID patient. At present, we are around 500 people who have passed away. But if it flares up, because we are 1 month behind America, once it flares away, the number of beds which may be needed, it may be so exponential. And the healthcare situation in India, though administration is strong, doctors are fantastic, but healthcare situation is not ready to take up a very big challenge. Next slide. So few situations wherein there was no option, wherein there's a patient who has an oncological problem and you have to proceed. Few of those patients went ahead, and the gametes and the embryos and the tissues were cryopreserved. Any patient who had suspicious of symptoms or there was COVID positive, and large number of these patients were the patients who had traveled a lot. A very surprise package we had, that though we had the annual conference between 6th to 8th of March with 2,500 people attending from all over the world. Luckily, most of the people went scot-free, but you cannot be lucky every time. So we want to avoid viral contamination of any infected patient or any professional within the lab, or any doctor or any lab person handling the gametes and the embryo. We have to have repeated washing so that you can dilute the possible effect We are aware that the sperm doesn't get, the oocyte doesn't get. Embryo till now, it was known that it should not be a problem, but there are receptors which have been noticed inside the zona pellucida. There are some papers which are coming. So we have to be careful that we only do essential and necessary during the lockdown and during the extended lockdown, and maybe we wait up till 4th May and see what the law of the land permits to us. Next slide. Obviously, we are overburdened with WhatsApp call, WhatsApp consultation, and almost everything is taken for granted. Through telemedicine, this has been simplified because it has become more organized, wherein you can interact with patient, irrespective of the fact that medicine and the telecommunication has advanced so much. This is the time you realize that suppose if there's an obstetric patient, even if you're on telemedicine, you can't do any clinical examination, you can't do sonography. So telemedicine is only to reduce the contact spread with patient and the community. And at least in India, a patient doesn't come alone, it comes with 3 other people who might have moved anywhere. So all infertility treatment are postponed. Counseling is very important because people are worried if they have low AMH, if their age is advanced, if their treatment, when it will start, because there is no rosy picture up till now that when the clampdown effect will change. A lot of people are worried about the economic impact because a lot of industries and all the funds which will be needed for this treatment, a lot of persons are worried because none of the infertility treatment is by any government agency or an insurance. Diagnostic procedures, whether it is laparoscopy surgery or elective surgery, is not performed. And the only thing which goes is, for example, a cesarean section, which you cannot wait, or an ectopic pregnancy, which is having definite hemoperitoneum. Good clinical and lab practice is strongly recommended, and we have to follow because number of lab people reaching to the lab itself are limited. So you have to see that all those people who are active and working, their duties are arranged in such a way that they remain without causing any problem. Next slide. Staff becomes very important because the more sincere and the loyal staff which is, they are also surrounded by people. So sometimes we had, in fact, one of the nursing staff in their area, there was some COVID positive. So we voluntarily told her that she can remain at home. And so we have to be very careful with the embryologists because movement of ambulatory embryologists is restricted, lab technicians is restricted. But we still have to maintain quality control to see that all the embryos are protected, all the medias, etc., are well preserved. Duties are kept in rotation. Quarantine of the staff is needed. Prophylaxis, chemoprophylaxis in patients who had exposure or had symptoms. If the test is showing some positive, then it may be considered. PPE, of course, it's needed when you are handling a surgical procedure. And frequent sanitizers, use of sanitizer, hand washing, and compulsory. Even if you do an emergency consulting of 4 patients, then it is seen that everybody uses mask, everybody uses the sanitizer, everybody has hand washing, everybody going close to the patient is taking utmost precaution. Maintenance of psychological health, mental and emotional, is very much necessary. And more important, it's needed to refer a patient when it is needed. And this reference has to be followed that the person has reached to the adequate place. Next slide, please. So if a patient is COVID positive, obviously no active treatment is done. Obviously the treatment of various types starting from hydroxy, chloroquine, there are many other drugs which are discussed, azithromycin and so on and so forth, which falls under the purview of just physicians. Decontamination with disinfection is very much needed. So maintaining the lab, maintaining the operation theater very well clean with appropriate disinfectants is totally necessary. In OTs where cesarean and other things are performed, fumigation is accepted, whereas in an IVF OT, it has to be a clear disinfectant procedure rather than anything else. Any tissue which is there is stored in a separate can. Though COVID doesn't spread like HIV and HBsAg through blood or sexual contact or transplacental, universal protection, as Dr. Agrawal mentioned, has to be maintained. Psychological health is not necessarily maintained of patient. It is also maintained of the medical faculties you have, of the nursing staff you have, of the lab people you have. And some larger unit do have counseling or teleconsultations amongst the doctors and amongst the staff also, which can maintain the distance. And there's one paper which showed that virus can travel up to 27 feet in air and can still remain. So there are a lot of new things which can pour, but we have to remember that we may lose a small battle, but we may win the war finally. And we don't depend on sprints as an opinion, because we are actually fighting and running for a marathon. Next slide.
And thank you very much, sir.
Yeah.
Thank you very much, sir, for the guidelines. And next we have Dr. Sudha Prasad, who is the president of the Indian Fertility Society. And the stage is yours, ma'am. And I would like you to just check your voice once. Could you please speak into the mic?
Dr. Sudha, please
Dr. Sudha,
unmute your microphone.
Please unmute your microphone, please.
Thank you. Thank you, Sunil. Can you hear me?
Yes, it's loud and clear.
Okay, thank you. So thank you for giving me the chance to speak among this eminent panelist. I am from the Indian Fertility Society, and I bring the greetings from IFS. We have IVF specialists all over the country and 27 state chapters. So you can imagine these specialists, how many patients are be looked after by these specialists. So due to this corona, actually all IVF specialists were in dilemma how to proceed, because the patient's anxiety and the morbidity caused by this, by the fear of corona was there among the paramedical and the medical staff. So this is the reason the IFS has taken over, and after seeing the situation of morbidity and the mortality of the this condition, which was really in a volume, so we have taken out the recommendation for our clinical staff, for the patients, and for the lab, how to deal with, and we are here to give you the recommendation from the Infertility Society. Thank you. Next slide, please. Next, please. So for the clinical setup, we had the recommendation that the new cycles of even IUI, including IVF, fresh or frozen embryo transfer, should not be done, because we exactly do not know what will be the effect of this COVID-19 on early pregnancy if they have the successful implantation. And only the urgent cycle initiated was the onco patients of the fertility preservation of these includes the gamete, embryo transfer, embryos, and the ovarian tissue cryopreservation for this cancer patient if they are going through some chemotherapy later. In this condition, I just want to tell you the decreased ovarian reserve was not made it urgent, because we got so much of pressure that see, my AMH is low, but this was not at all urgent situation to make during this period, we should start the cycle. And if it is already initiated, the self cycle or the donor cycle, it was completed during this period because already we are more than 5 weeks. So it was completed and all the oocyte or embryos were frozen in a separate tank. So all elective surgery, like a major surgery, were stopped. The laparoscopic route of the surgery were also suspended because we do not know the aerosol transfer will be there. We can get COVID infection and it can make more and more morbid condition of that patient. We started doing the teleconsultation on email and the WhatsApp. Of course, this is very, very difficult when the eye-to-eye movement is not there. The patient were not very much satisfied. But yes, they were knowing their situation is like this. And our patient I have found out from our specialist that they were very much concerned and they are quite making okay by their teleconsultation. Next, please. Next slide, please. Can I have the next slide? Yeah. Next recommendation we have made for the embryology lab. For any ongoing cycle, there should be a very strict protocols should be kept. The lab should be cleaned with the intensive disinfection. All cryopreserved specimens should have the separate cryo tank because we exactly do not know whether it will transfer if we will keep in the same tank because still it is in the learning phase. We exactly do not know what will be the situation. Intensive washing of the gamete and embryos is mandatory if it is done during this period. It has a many labs, so there should not be any transportation of embryos or gamete between the clinics during this period. They have kept the strict written protocol to maintain the cryostored gamete and the embryos, including the liquid nitrogen levels. So liquid nitrogen, from where it is coming, how it is putting, this is also one question mark. But yes, there should be a clear-cut written protocol for the paramedics to maintain this cryo-stored gametes. Next, please. Next slide. There was the recommendation for the staff who all are working in the clinic. They have to use the mask, head cover, gloves, even in OPD. And if the follicular monitoring is done, they should wear the gloves and there should be little distance. The hand washing with the soap and water is must. People started for the sanitizer and the sanitizer became out of market. But simple washing with the soap and the water is more than enough if the sanitizers are not available. It should be done before and after touching to the patient. Of course, the social distancing of 1 meter was recommended by everybody. We should try to make that. And we have started doing the shift duty between the doctors, between the embryologist, and the paramedic staff nurses and the Safai Karamchari who all were working there. So it was done in a shift wise. So everybody is not coming at a time. Infected patient, of course, if it is COVID positive, it should be kept away. It should be quarantined either in the hospital or in the self-quarantine at home. The ICMR here has taken the prophylaxis of hydrochloroquine can be given, but it is just a prophylaxis. We should not forget that you have taken the hydrochloroquine, so you should start walking, you should start doing their own job as before. No, you have to maintain all the parameters which was recommended, and it has to be prophylaxis can be taken during this period. Next slide, please. Next slide, please, Dr. Ashok.
I'm trying to move it.
Oh, sorry. Yeah. So this is an important aspect, the psychological support. As soon as we became locked down, so the phone calls started coming that what will happen to me? The patient started thinking about that lockdown will go far off, and they are taking the test, they are taking to make the cycle. So they have started about questioning that how this will be over and how they will be treated. So psychological support to the patient is utmost, considering the despair in those women with infertility, and they have to be when the situation will be clear. And of course, this situation of treating these patients is not that emergency that has to be treated immediately. So we have to give the full assurance to these women. Staff also should be trained that they should handle with illness and the concern of the patients. This is very much important. Next slide, please. I can conclude here the available evidence, the ESHRE and the ASRM has given a very beautiful recommendation, but still it's not that robust. And based on the small case series, Indian Fertility Society is watchful for the situation, which is very dynamic and changing very fast. So we have to be very careful about the situation, and when we will open up on the 4th of May, we do not know what all will happen. So we are absolutely watchful, and we will be regularly assessing and updating our recommendation. This is from Indian Fertility Society. Thank you.
Thank you very much, ma'am. In fact, we really do not know whether we'll open up on the 4th of May, because it's a very big question in front of us. And another thing is how we will open up, what we would do. It still is something we really do not know much about. Dr. Nandita, I think people were waiting for you. We are 970 people. At the moment when we started, we were 600. 600 people were there to listen to me. But the moment you have started coming over, it's become 970 people. This is fantastic. Dr. Nandita has been the president, the immediate past pregnancy of FOXI. There's so many things, my gosh, she's done, orations, awards, chapters. I just wonder where to begin. But I think the best would be, we begin from your voice, ma'am. It's up to you now.
Thank you, Sunil. Thank you. First of all, it's a real pleasure to be on this Global ART Forum. I think I should thank INTAS for actually thinking of the concept and getting together Ashok, Sunil, and Hrishikesh. Thank you very much. So today, can I have my next slide, please, Dr. Agarwal? Yeah, I will be speaking about the guidelines of FOXI. You know, I'm probably one of the few IVF specialists who has a passion for IVF and also a passion for obstetrics. And there are a lot of patients of mine who were pregnant and who came up with a lot of questions, you know. I must give you an example of one of my friend's daughter who had done IVF in Bombay and then landed up in America, and she had to go to work. She was a frontliner and she turned out to be positive. And what I realized over there is there's a lot of difference in treatment in America and in India. And I'm going to give you what our guidelines say so. Yeah. So, you know, FOXI formed a group of gynecologists, the KOLs, and we released these guidelines on 28th of March. And there was a lot of thought process which went into it. A lot of people contributed. And I think they're really beautiful that if a patient is pregnant and with COVID, what should we do? So first thing that is important is social distancing. You know, and I just want to tell you that we need to look at this very, you know, there's a lot of depression there's a lot of fear about what will happen, life, economics, etc., etc. So we have to talk to our patients very positively and give them a lot of confidence. And I think the first thing is to try not to spread the disease. So what has FOXI come up with? Social distancing is the single most thing that can help in halting the disease. And do the 5. I think that is very, very nice to tell our pregnant patients: stay at home, hand hygiene, respiratory hygiene, avoid touching the face, and keeping distance. I think this is, yes. Hello. I don't know why this is ringing. Okay, sorry. Sorry about that. I think it was a Skype call from somebody. So do the 5. And I think this is very important to inform all our girls, because especially staying at home, I was asked this question: what if I'm in an essential commodity job? Then please go, but maintain these other things. I think you, at this point of the lockdown, the essential commodities, you have to go to work. Secondly, the precautions for the healthcare workers. You know, we heard a lot of speakers, in fact, Dr Blockeel, and who told us, and I think Pankaj also mentioned, that number of healthcare workers which are affected are very high. So we've got a lot of instructions for them also. So they are at high risk. Precautions are necessary to protect themselves. And also, you know, we come in contact with patients who may be COVID negative. So we have to prevent the spread. So basically, distancing, personal protective equipment, um, covering of all the surfaces, especially of the hands and face, is very, very vital. And the proper technique also. If you're handling COVID positive patients, I think you need to know the technique of donning and doffing your PPEs. And chemoprophylaxis. In India, the Ministry of Health and Family Welfare and the ICMR has laid out guidelines that all the healthcare workers who are in the front line should have a prophylaxis to with hydroxychloroquine. The only problem is, like I was talking to somebody today, and a group of hospitals has said, no, we don't need to take it. So there's a lot of controversy. In fact, the WHO also is not very sure whether it should be taken. But in India, as of now, we are following these guidelines given to us by the Ministry of Health and Family Welfare. Yeah, Dr. Agarwal, can I have the next slide?
Yeah.
So the clinical presentation is most of the women will have mild symptoms and a similar course to the adults. A history of travel, contact, or respiratory system should be elicited at every clinical interaction. And you know, since 28th of March, when it was released, now we know that 30% of the patients will actually be asymptomatic. So we have to really, you know, do it universally. Think that every patient is infected and treat her accordingly. Testing for COVID-19 in pregnancy, the FOXI says that we follow the guidelines given by our government. That is, testing only if there is a history, of travel, contact, or being a healthcare worker, or you require hospitalization because of the symptoms. But nowadays, in a lot of cities like Bombay, where I practice, I'm doing the RT-PCR test for all my pregnant patients. So it's available in a few cities now that you can just do the test. The other thing is the rapid testing is not yet available, but once it becomes available, I think we will need to use it in our practice. Can I have the next slide?
Yeah, just a second. Yeah, hello? Can you see it? Sunil?
Yeah, I have a feeling there has been some problem with the net with Dr. Nandita's system. I think it's got, I think there is some problem with the net over there.
Or it may be muted.
No, it's not muted.
No, it's not muted. Even
you can't see her.
One minute, I'll just find out whether she's has any issue. I'll just hold on for a moment.
Okay.
And so you're getting disconnected when you're changing the slide. That's what she's saying. That every time the slide is changed, it gets disconnected. So what do you want?
I think
Should we come back to you? Let me finish. She's trying to connect again. You know, every time there's a problem with the signal. Maybe what we can do is that I can.
Yes, Dr. Hrishikesh, if you could continue with this, please.
Yeah, I think I can continue the slides and then come back to her.
Right.
To the British slide. Then by the time she dials in, we can have her few slides.
Yeah.
Correct.
That's a good
Ashok,
idea.
can you go to the British guidelines?
Okay.
I think madam is connecting now.
Okay, just see.
Sorry.
Okay.
I'm back.
Are you back?
You are
Okay.
back.
I'm back. Sorry. I think
We were on this slide, I think. This one?
Yeah, this test I've already spoken about. Let's go to the next slide.
Next slide, please.
Notification of the cases is really mandatory in our country. So if, like, as I was telling you, my friend's daughter in USA, she just stayed at home and she didn't take any treatment and she recovered from COVID, though she tested positive. But in India, it's very necessary. We need to quarantine them, and as per, depending of whatever is there for the general population. Effects on the mother and fetus are very, very important. The studies have so far have shown that there is absolutely no vertical transmission between mother and child. But let me tell you here, there was a publication on 26 January, which actually says a 29-year-old who delivered, she was tested positive on 2nd February and delivered on 22nd February. Her baby, 2 hours after delivery, had IgM in the cord blood. So they're wondering how, because the IgM takes 3 to 5 days to come in the blood. So that is another question mark which we have, but definitely not. So far we know that it does not go through. Then I think arrangements have to be done, and I'm very happy to tell you that Foxy's guidelines have been taken up by the different governments of the various states, and we are having separate labor rooms for COVID positive patients. Next slide.
Okay.
Next slide. Yeah. This is very important, that termination of pregnancy and the contraceptive advice which is necessary. And here Foxy has said that telemedicine should be used very aggressively, and MCI has permitted us, made it legal. So termination of pregnancy and contraceptive advice should be available, especially during this pandemic. Assessment of the women not in labor, I think obviously, it's the same thing. We have to recognize the critically ill woman, tachypnea greater than 30 per minute, hypoxia, SpO3 less than 93%, and an imaging of at least 50% of the lung involvement. Definitely, she needs to go into critical care. And the medical management is what we are using in India, and what Foxy has recommended is hydroxychloroquine 600 milligrams 3 times a day with meals, azithromycin 500 milligrams per day for 10 days. And the units are using this unless there are other complications. Then lopinavir and ritonavir is definitely being used. Tamiflu is also being added to the patients. And just to give you an update, remdesivir is the new drug which is being, trials are being conducted by the WHO on this drug so that it can be used. And I think there's one more slide, sorry. Yeah, can I have the next slide? Management of labor and delivery, I think that's very, very important for you to understand. The timing should not get affected by the COVID-19. It should depend on obstetric indication if you want to do a preterm delivery, unless the woman's life is in danger or she requires a lot of rest, she has a lot of ARDS. Then the mode of delivery also, actually the WHO and the Foxy says you can deliver them in whichever, cesarean or vaginal. It depends on the obstetric indications for the mode of delivery. Though all the studies so far which have come in, about 98% patients are delivered by cesarean section. Labor analgesia and anesthesia, there is no question, regional anesthesia is the drug of choice. But in case it fails, you need general anesthesia. You have to take really specialized care because aerosol spread can be a big deal. Neonatal care, very important to remember that at present, Foxy says that if the patient is positive, you can still breastfeed with good hygiene practices. And some of the people say that we should not do it. Next, the last slide, please, Dr. Agarwal. Oh,
I think that was the last slide.
was the last slide. So I think overall, we must remember that not only in IVF, we get them pregnant also. So our patients are going to ask these questions, and we need to really remember what to do. And I think telemedicine will really play an important role. So thank you, and over to you, Hrishikesh.
Thank you very much, Dr. Nandita. Now we have Dr. Hrishikesh Pai. I don't know where to begin from and where to end. But the only thing I know is he's been the past Secretary General, Vice President, Deputy Secretary General, Treasurer, Chairman, everything of Foxy. The only thing he has not become deliberately is the President of Foxy. And this is interesting, which only he knows why he did not do so. Everything is there. And apart from being a professor, a teacher, a writer, everything, he's a great person. So Dr. Hrishikesh, on to you for the presentation of the British guidelines.
Thank you very much. We don't have much time, so I'll quickly wrap it up. I would like to thank all of you and Durga, who is silently listening to us, and Intas for their educational support. This is a summary of the British society. Actually, it's just the Brexit has made it different. Otherwise, they would have been along with the ESHRE in the same recommendation. So, can I have the next slide, please? So, if you look at the first recommendation, what they have recommended, pregnancy should be avoided in women who display symptoms of COVID-19. And patients who are in the stimulation phase of this treatment but have not started the, can receive the trigger but should be advised treatment cancellation. So if they have not started the full treatment, they can go for a cancellation. This has already occurred. So most people, like even our group, we cancelled nearly 100 ovum pickups in the last month of, that is just the previous month. Patients who have received HCG or GnRH agonist trigger may proceed to egg collection and freeze-all strategy, which is obvious. Embryos and eggs can be frozen. And patients who develop symptoms after oocyte collection should not have an embryo transfer. You should defer it. You should freeze the embryos again. Embryo transfer or intrauterine insemination should not be carried out in women with suspected or diagnosed COVID-19. So at this stage, I would just like to mention that symptomatology is a big problem, and nearly 30% of patients are asymptomatic. And this is the biggest problem, because at that time when they are asymptomatic, they can transmit the infection. So this has influenced all the recommendations, the present ones and probably the future ones. Coming to the stopping of the treatment programs, UK epidemic is now proceeding. All centers will stop initiating new fertility treatments, including IVF and all the allied things like endoscopy, etc. When such a decision is made, it is reasonable for clinics to complete treatment. As I have already told you, that the clinics have almost completed all the treatment. I think none of the clinics are actively operating at present in UK. However, clinics should be mindful both of their duty to minimize spread and impact of any complications on the NHS. Moderate or severe hyperstimulation syndrome especially should be avoided by giving GnRH agonist trigger and freeze-all. See, basically the whole worry was that if there is a complication, it will burden the system. The whole resources are being directed to support the COVID patient, and they don't want any other patients trying to take away the resources because of the high mortality rate, as Dr. Ashok Agrawal and many people have mentioned. Nearly 50% mortality is there on the ventilator. Next slide, please. If you look at fertility preservation, only those patients, so emergency fertility preservation can be done, emergency sperm or oocyte or embryo storage for cancer, only for, because these patients are also compromised, and if there is a concomitant COVID infection or an infection sets in while you're doing the procedure, that can also create a setback. So it should be borne in mind that this patient may be immunocompromised, and the decision making should be shared along with the patient oncologist and fertility specialist. Fertility preservation should only be carried out in patients who remain well during treatment, and provided sufficient resources are available to do this safely. Local arrangements will be needed to allow these procedures to take place. Next slide, please. If you look at the support and communication, clinics should be aware of the potential emotional impact of the treatment. Measures should be put in place to keep patients informed out of the changes in service. All members of the clinical team have a role to play in supporting patients. Psychological support is very important. It is recommended that usual facilities for answering phone call queries be enhanced to account for an increased demand around short notice changes in service provision. And clinical websites have, just like in India, a lot of people are resorting to communication through apps and website. Next slide. Is there staffing? This is, I think, the last one of the centers should work to identify the minimum number of staff. And Dr. Sudha also said that the staffing is very important and that are necessary to maintain urgent services such as fertility, preservation of for oncology. Even freezing liquid nitrogen, topping up of the containers is very important in this area. We ourselves have faced a big problem in topping. We have nearly 45 containers and it's been a nightmare trying to do the logistical arrangement. Sufficient scientific staff should be in place to maintain and ensure ongoing safety of gametes and embryo storage bank. Just as I told you, it's a logistical nightmare at present in our Mumbai, Delhi, etc. Centers should ensure that sufficient scientific staff is available and are cross-trained to deliver all key tasks, including ongoing quality control and maintenance. And appropriate levels of staffing should be determined by the person responsible, taking advice from nursing, medical and scientific professional leads within the center. What I wanted to summarize is that there is a risk to the, because the patients are asymptomatic, there's a risk to the healthcare worker and the staff. And yesterday I was listening to one of the lovely lectures on this, and the testing is going to be very important. Testing. So we may have to do a lot of testing of the patients and the healthcare workers, and the PCR test as well as the antibody test has to be done. The recommendation is that to do the testing every 7 days. I have thought of doing testing every 10 days. And as far as I am concerned, I am also thought that if at all there is any active patient going in, for example, there's an emergency oncology patient going in, she should be tested before we enter her into the program, because she may be in the asymptomatic stage of the disease. There's of course the financial problem, and the final thing is that when we come back, and I think that's a second symposium, how do we come back and how do we restart the clinics is going to be the next challenge. So thank you for your patient hearing as far as my take on the British Fertility Society is concerned.
Thank you very much, all the panelists. It has been amazing. And now we have about 200 questions, but we will probably only be able to answer a few. So I would request the first question, which is very interesting. A patient with COVID can be referred to a COVID hospital, but a carrier can still infect a surgeon. How can a surgeon in private practice protect himself or herself better in the absence of strict testing criteria? Anybody from the panel could answer this. Or I would probably ask Dr. Trivedi, Dr. Prakash Trivedi.
Yeah, Sunil, thank you very much. I think so. First primary thing is we have to understand that any patient is positive unless proved otherwise. If you have that philosophy, then you can manage such patient. Before we go into this question, one very broad misunderstanding which lots of leaders have mentioned as far as laparoscopy is concerned. Number one, the aerosol of CO2 has nothing to do with the spread of disease. As Pankaj rightly pointed out, it are particles which survives in lung. So it cannot suddenly go, because it doesn't go by blood, it doesn't go through the distension tubing. So it's impossible for the virus to enter the peritoneal cavity. That is point number one. Keeping pressure low or keeping less Trendelenburg has no role. The plume, which is always told the aerosolization. Aerosolization of the anesthesia is different from the aerosolization of intraperitoneal. So the plume which is going doesn't have the virus. And even if you use harmonic or heating device, they will kill it. So that is point number one, to have that laparoscopy is overall acceptable, and it's not compulsory to give spinal anesthesia. The maximum risk person is the anesthetist, the ENT person, and we who are close to the anesthetist. And as we were mentioning about mortality, when we were telling 50%, please remember below 44 years, the actual mortality is only 2%. So it's only when the age is advanced and only medical people who are young gets exposed to this problem rather than the
Correct.
Yeah,
Correct, sir. But the interesting thing which the person really wants to know is, how can a surgeon in private practice protect himself from the cases which may be in the incubation period when you just do not know?
Yeah, so see, to be precise, we have a similar case wherein it is surgery for malignancy. So we have done our test, we have done our antibodies, we are waiting for a 14 days window period and then taking her up. Second is, I was just discussing with somebody in Agra where it is much more spread out. There are many physicians or many operating people or consultant or dealing with so much of delivery, they are prophylactically taking hydroxychloroquine themselves and repeating after a week. So that is one thing which can be not a take-home message, but that can minimize your risk to the problem or the condition.
Yes.
Of course, PPE and the mask and all
that needs to be done.
Level 3.
There's another thing there is another thing at the moment which I particularly feel, and that is that the PCR testing is now available, and this PCR testing is now available to the private labs. So any patient before you taking up for a surgery can be tested.
Yeah.
And you can test the patient whether it's corona positive or not, and only after that you could take an elective patient.
Yeah.
I would like to request Dr. Nandita if there is anything which she would like to add to this. You'll have to unmute yourself. Unmute yourself, please.
Sorry, we are talking about the same question. I was talking to Dr. Agarwal to unmute his, to take off the screen sharing. So everybody would be on the screen. Yeah, that's better. So if there is a patient in your practice, that's what, I'm sorry, I missed the question.
No problem. I'll ask the next question. I would like to know if Dr. Blockeel is here. Is he here?
I think he had to leave.
He had to leave probably. Now, the fact is, this is something which everybody is facing. You just do not know whether the patient has corona or not. Most of the patients are asymptomatic. The patient comes to you for an elective Caesar or a patient comes to you for a delivery. What should you do? Yes, please.
Now I will answer that.
Yes.
Okay, Sunil, see, first of all, in Bombay, we are testing all the patients for RT-PCR if we can. If it's an elective section, we try and do the test before we can keep her. Now, supposing she comes and you've not done the test, you have to treat her like taking universal precautions. You know how we did it with the HIV when HIV first came. So we have to treat every patient because asymptomatic transmission is now there. Definitely, there are a lot of community-based infections which are not with history of travel and history. So you have to take your precautions. Cover your face and mouth.
Perfect. Now, the second question is, there a patient who has come to you, she's for a delivery, an elective Caesar. She has influenza-like symptoms. Dr. Hrishikesh, what will you do?
So basically, as Nandita said, that you have to protect yourself with universal precautions for every patient now, because there may be people who may be in the asymptomatic in the latent period. Yesterday, I was listening to Luca on the net, and in Italy, they are going to bring back the IVF program. So he was saying, and even Kuzi was saying the other day, that you must do both the tests. That is the RT-PCR, because there's a false negative with RT-PCR as well. RT-PCR test can sometimes come negative when the patient is positive. So you must do RT-PCR and the antibody test, and that test should be done every 7 days for all the staff, healthcare workers. And as far as the patient is concerned, you have to plan it 10 days. Suppose there's an elective procedure, 10 days in advance you have to plan it. If there is a non-elective procedure, you must do it before entry.
Okay, now I got it. So now we know one thing for sure, that we have an RT-PCR which is available. Now the private labs have started testing before taking up a patient or expecting a delivery or an elective cesarean section, or before a patient you know is there in the 8th, 9th month, you would like to get a COVID test done. Okay, now if it is available, fine, but it is not available in a lot of places in our country. That is the way it is.
So,
Dr. Talwar, so yes, please.
No, so that's what I'm saying. You need to take a universal precaution, but you're missing the point. The danger can be that the anesthetist may be positive, not the patient. That is why the staff has also to be tested. So like in our protocol, when we start the IVF center again, we will test the staff every 7 to 10 days and we will test all the patients and go through. That's the only way. Otherwise you can't. You take the universal precaution, but you have, so testing is the only way to get out of this situation.
Now the problem in our country at the moment is that testing is not available in this fashion that you regularly can get everybody tested. Unfortunately, sir, I wish it were there. Now there's another question which has come up. In labor patients, what are the screening guidelines for COVID? One. Number two, in COVID suspects, how to go about conducting labor, particularly in reference to PPE use. People do not know about it. Third, because PPE supply is limited, what is the minimum requirement? Can the PPE be re-sterilized or can we use it again? This is the question which is very pertinent to most of India. So anybody would like to answer this question? Dr. Nindita?
See, basically, if your patient is positive or has symptoms, first and foremost, you need to know in our country, you have to notify. They cannot be delivered at your nursing home. It has to be delivered in a COVID hospital. So that is something we have to inform everybody. Even your previous question where you said she has symptoms of influenza. Well, if a patient has symptoms of influenza, you have to triage the patients on the phone itself. So if she has symptoms, send her to a COVID hospital for testing. Do not let her enter your facility. In your facility, you're going to only handle asymptomatic patients, and that's why you need universal care. So, okay, the second part of your question. You want to say something? Okay, second part. The second part of the question is you have to use PPE when you deliver these patients. Basically, all the open areas, if you've actually seen the PPE, the face, the eyes, the ears, the hair, the hands, everything needs to be covered. So actually you need to be completely covered, and putting on that PPE, removing it is a big deal. Now, most of the things cannot be re-sterilized except N95. Okay, N95 can be re-sterilized by putting it in soapy water or 1% hypochlorite. Yeah.
Now I'm just opening this for discussion because there was something which I felt needs to be answered. Now, one PPP kit costs about 900 rupees today, a good kit. Now this 900 rupees today for most of the places in the country is a very big amount if everybody is wearing it in the staff. If this PPE kit, which actually is plastic, if after using this, a spray of hypochlorite could be taken, and just like the N95 mask, if you had 5 masks with you, 1, 2, 3, 4, 5, why can this PPE kit be used in the 1, 2, 3, 4, 5 system? This is a question which I've always wondered, and a few people have planned this in this fashion. Anybody would like to? Yes, sir.
Sunil, can I tell you one thing? One is the most important thing which is missed is what Nandita told is correct. You have to have an apron which is waterproof, because when you are having Caesar, you are going to have amniotic fluid, you are going to have blood. So you have to. Second is, Sunil, you know a lot about endoscopy. When we go from a single chip to a 3D camera, so the same thing happens when it is for PPE. You have to keep a sufficient stock. If the patient cannot afford in this period of time for your self-protection, you burn your own pocket in service of the women. You can't compromise, because you can't compromise your staff, your anesthetist, your main assistant, who may be son, daughter-in-law, or anybody, or everybody is important. So basically, you have to invest on that when no repercussion.
So we need to use PPE for every patient who's being operated,
Very
and it
right.
has to be complete PPE, right?
Level 3.
A level 3 PPE.
Can I just make one important point here?
Yes, please.
See, there is a lot of variation in the PPE, and that is a problem. Because of that, the healthcare workers are all getting infected because they are doing raincoat and this and that. This is a very lethal virus, the most infective virus. You have to use a CE mark or a ISO 16003 with the fabric has to have a GSM of between 100 to 150. A lot of these fly-by-night operators are there. They are giving you PPE at a very low cost, and usage is very dangerous.
Sunil,
Absolutely.
One small point, Sunil. I think so, for the want of time, I will send the entire sanitization and levels of PPE to you, which can be circulated to everybody so that we have a standardization.
Correct. Correct.
Dr. Jindal, I want to make one point.
Yeah,
Yes,
Dr.
please.
Jindal,
Yes, please.
See, we are talking about a lot of PPEs and a lot of things. They are very, very important. But one thing is, which we all have to follow, is the minimal contact with the patient. So we did a small study. Let's see, we got one patient who is a suspect. Everyone is a suspect nowadays. COVID will go to a COVID hospital, as Dr. Nandita brought out. We found around 20 to 24 people were seeing that patient in an interval of 3 to 4 days in the hospital. And in case we have done RT-PCR that may come negative, that patient may be positive and infecting around, say, 25, 30 people in 3 to 4 days in case she's admitted there. So what we advise is that minimal number of patients should be seeing that patient. The healthcare workers should see that patient. And the number should be brought down to not more than 5 to 6. And these numbers should start from the housekeeping, the front office, the people who serve food. So they are the people who will actually infect.
In fact, I was waiting for this thing.
That should be done.
Yeah, for the prime reason that there are a few guidelines which were there of the IMA Hospital Board, which came to me, which would be there, which we would be sharing in the end with everybody. Everybody could download them, which is fantastic. And this was exactly something mentioned over there.
Doctors are always very careful. We wear PPEs, we do a lot of things, but for the people who are serving food, housekeeping people, they don't wear goggles,
Yes,
they don't wear PPEs.
yes.
They are the ones who are actually the hotspots in the hospital.
Correct. Now, Dr. Pankaj, there's a question for you, which I'd like you to answer. What are the precautions should expectant mothers take during lockdown situations? Anything more than the routine guidelines? Every patient who's in anxiety today at home, she's locked down, she's pregnant. There's this thing which she always wants to know.
I'll take your, we do a lot of telemedicine. And I just, go a bit of tangent to what you're saying. Every day I get one or two consults about a young girl, a young woman who says I'm pregnant and I want to abort. And it's all lockdown. This is one condition. Second condition is a lady, a young woman who is pregnant and who has got an early pregnancy of 6 or 7 weeks and who's having a severe pain abdomen. What to do? We are having a lockdown. Can it be ectopic, doctor? Can it be a normal pregnancy? I'm having giddiness. These are a few things which come to our mind.
No, but I'm also asking about an expecting mother. She's running the 4th or the 5th month.
So the only
anything
thing
extra she needs to do.
Yeah, extra things are that we always tell the patient that as we're having a lockdown, you should not be meeting anyone. We are always telling them to have minimal support at home and not go out of home. That's all we can do. And in case she has any problem, then in that case, she has to contact a gynecologist. That's what I would like to put across. In case
Sunil,
you can more, you can.
I will add.
I can add a little thing, Sunil.
Right, sir.
Two very important things. First of all, counsel the patient that she is pregnant like any other phase, not necessarily in the COVID phase. So she doesn't have that much anxiety, and you tell that the child usually is safe. So that gives her relief. The biggest relief is you tell that you are available 24 hours a day, 365 days, either in hospital or on phone or on your communication, because they are basically more interested that whether you will be there or whether a proper person will be there or not. And what we have done is we have done 2 sisters who are fixed in duties, 2 of the best sisters, and that is how we are trying to do. They are more concerned whether a proper doctor will be available or not. Once they are happy with that, Then you add them the other prophylaxis, and you pass the material about COVID and tell these are the primary thing which you have to remember. Madam Sudha Prasad, you are adding something.
Yeah, I just wanted to add, Dr. Trivedi, already you said that anxiety of these patients should be decreased by giving the moral support that somebody is available if something happens. But the pregnancy itself is a immunosuppressive problem. So we should give them advice to make the immunity to be increased by adding some vitamin C, or by adding some good green vegetables. If little sneezing or some viral like features occurs, they should be very, very careful about it. So they should drink a little lukewarm water and gargling and the breathing exercises. If you have tested it is not COVID, so the anxiety will also decrease, and they will have the more they will feel better. Of course,
I have received about 12 questions on gargles, and really, and it's a very important thing. I have received one: how often should the gargles be done? Should they be done with soap water if possible? I have received these are the questions which are there, and I have received: should these gargles be done with povidone iodine? What should be the temperature of the gargles? Because probably at the moment, the WhatsApp University actually has brought in a lot of things. So I would really want to know, is there any role of any guidelines for any kind of gargles? Madam Sudha Prasad, since you were talking of the hot gargles, I really want to ask this one.
No, gargle is not going, if it should be added something, or it should be give some other support. The only thing that the throat, the soreness should not be there, that the other person will be absolutely scared. Okay, she has a soreness, she had. So nothing will happen if you add something. Only the lukewarm water gargle is more than
now there is one question which is the
Sunil, one second. I'll
yes,
give
please,
you a different our anesthetist who is the senior most, and he picked up a very important thing, and he suggested that warm water with lime and fruit salt 2 to 3 times a day. That is what people in Israel are having on regular basis, and that is where the incidence is less. So if at all you're doing something,
I think
water, lime, antioxidant, and because it alters the pH, and that is why you have a lot of COVID in stools, but it doesn't go into the blood system. So that's just
right. And now there is one question which is been asked about the 25 questions of the same. I mean, the question is the same. Now, one is, in this pandemic, is it mandatory to screen every patient before a procedure? What tests should be done before the procedure? How often this test should be done? And should we confirm the COVID status of the patient before vaginal delivery or an LSCS?
Yes.
It's open to the house. And I would really like this is a question which has most commonly been asked.
Dr. Jindal,
yes,
what we are doing is that in case we expect a delivery to occur in a certain time, we are always doing home testing for the COVID.
How many days prior to delivery?
When we plan a normal delivery or an induction or a cesarean, we do it around 1 to 2 days before the delivery or a cesarean.
How much time does it take for you to get the report now?
The report is available in 8 to 9 hours, because normally all the good labs in Delhi are running 3 batches a day. Initially, we had 1 batch a day. Now all the good companies are having 3 batches. So in case we give the sample in the evening, we get the report in the morning by 9 o'clock, or in the morning we give at 12. By 7, 8 in the evening, we get the report. In case report is positive, it goes to ICMR. In case negative, patient is informed. So what we are doing is that for a normal delivery or a cesarean or any planned procedure, we always carried out COVID testing. Yes, we got a very pertinent thing. How many times we should do? We do 1 test that can miss the patient. But due to the economical reasons, we can't tell them to repeat the test every 48 hours or 72 hours. So what we are doing is presently doing only 1 testing. After that, we admit the patient. And even if the report comes negative, we always should have complete level 3 PP, so that in case the report is negative, we shouldn't have cross contamination.
Right. So now there was another part to it, and the other part was which test should be done.
Can I just?
Yes, sir. Please.
Okay, so now one of the hospitals, I will not mention it, where I am there. This is for the elective, but there's a lot of emergency work that is coming in. So there was an emergency procedure, patient was done, and the test was done, which came positive 2 days later. So they had to quarantine everyone who touched the patient. So now the new rule that has come in the hospital is that every patient, there are 2 tests that are done: the RT-PCR for the emergency patient and the high resolution CT. If it is a pregnant patient with the abdominal shield, because the CT can pick up a lot of patients which are by the lung, whatever manifestation and presentation. So this is the new recommendation that has come in one of our corporate hospitals where we are attached. So and this can be used because a lot of patients may not have availability of the PCR test in their, say for example, in a small town, but there is a availability of the high resolution CT. That is one point I wanted to make. And the second point I wanted to, again and again, I would like to make this point, that you must test all your healthcare workers. The biggest threat to all of us is the anesthetist, because he is going to induce hundreds of patients. And if he is infected, he'll infect everyone. So I have at least decided that I'm going to ask my anesthetist to do a test every 7 to 10 days when I go back for routine work. That is the second point I want to make. And third is, you have to treat every patient as a potential COVID. So you must take all universal precautions. So these are the
Sunil, one small important point.
Potential health workers.
Sunil,
yes,
I was
please.
having this COVID interaction with the AGL for 2 hours plus and all. And fortunately, the person was moderating. She was a oncologic laparoscopic surgeon. And important thing what Hrishikesh also pointed out, that patient was otherwise everything fine, scheduled for surgery, laparoscopy. I shed a lot of doubts which people have, forget about it. But the last point is, they just did a CT of chest. Things were negative, but CT of the chest showed something and they postponed, and she turned out to be positive. So we have to have more than one parameters for evaluation when there is a suspect.
Sir, I have got a fantastic question, because these questions are great. An asymptomatic patient, we do an emergency surgery, could not test for COVID. Post-operatively, the patient goes into RDS and dies, confirms COVID status. And then,
very rightly said.
Yes, and then it is that staff get positive, shifted to government hospital, and there is a claim of negligence on the hospital. What should be done? What should we do? And how we should go about doing this? The first and most important thing is that there is a consent form of any patient who comes to your hospital, which needs to be signed in Hindi as well as English or the local language. The consent form of which we have, which we would be giving you in the link one. But apart from that, madam, what can be done, sir? What can be done? Please, anybody.
I will tell you one thing. If you test 1 or 2 days before, it is not going to help, because the patient may be asymptomatic and she can have, after 5 to 6 days after the symptoms can come, maximum of 14 days after. This guideline already has been circulated by WHO. It has been written very, very clearly that pre-symptomatic transmission, the incubation period of the COVID-19 is very, very variable, and average is 5 to 6 days and maximum of 14 days. So one can make out, if it is done 1 week before, then probably you are more safe. If you have not done it, then this is a wrong attitude. One should do it, because at least in 3,500 rupees, the private sector is doing RT-PCR. Government of India has not procured at present about the screening test of the COVID. So this is must in today's date.
Sunil, can I tell one important thing which Gopinath Shenoy always used to point out?
Yes, please.
Negligence by a medical person can always be nullified, because in court of law, a care is expected and not cure. When you have done a negative, when the test was negative, if she comes out positive later on, it is a risk to the patient, it is a risk to the medical system, it is a risk to the nursing staff, it's a risk to the doctor. And in court of law, nobody will support the patient, and you can easily come out of negligence. But other way around seeing it, you again have to see yourself that we are exposing at so much of risk.
Right, and there is a small consent form in the languages which can be filled by everybody, which we would be attaching now. Another question which is asked, which is very pertinent, is there are about 12 people who've asked this question. How should we go about doing pregnancy scans?
I think that is very important. You know, the OPD care that you need to take when a patient comes is very, very important. So first of all, it has to be handled very properly, that the patient has only 3 scans during a full 9 months. Don't do unnecessary scans. And when she comes for a scan, schedule the appointments at every half an hour to 45 minutes. Tell her not to get 5 attendants, as Dr. Trivedi said. You know, one, her husband can come with her. And when the patient should be masked when she comes on your table. Okay, the mask for the patient, the people in the clinic also should be wearing gloves, mask and all. Every time she enters the bed sheet is changed. So you have to use disposable sheets all the time. Then the probe needs to be cleaned also properly. So
Sunil, one very relevant point, Nandita, can I add? I had a patient who came and he told the sonologist, because if you remember, sonologists have a small, dingy room.
Yes.
And they are not used to any PPE and all of them. So she told that the sonologist who did her sonography is tested positive.
Oh my.
So 90 patients, this is somebody in Mumbai only, but 90 patients whom he had screened, so those screened patients were in isolation. So basically you have to inform the sonologist, there should have been more space, separated appointment, and they have to use at least level 2, if not level 3 PPE protection, and be very so as Hrishikesh was telling that the anesthetist can give you.
Sonologists are also good.
Yeah.
Fantastic. And now I think we'll have to wrap up the question answer for the prime reason. We've crossed about 1,000 people, but we're also going to cross 2 hours. So I think it's time. We've crossed a lot, and there is a lot we have done. There are a few take-home messages in the end, which would be like to be presented, and a vote of thanks. So Dr. Ashok, can we please move on to that, sir, please? And thank you very much, esteemed panelists. You have been just amazing.
Thank you.
And even the people who have joined us, there were such fantastic questions.
Sunil, your moderation was excellent, and Inta's support was great, and all the panelists were great. Dr. Agarwal.
Please stay on. Just wait for a few minutes. Don't leave.
Please wait for a few minutes.
You have been waiting patiently. We have to listen to your summary.
Now, it's for 2 reasons. It's for 2 reasons. Number one, this is just the summary which all of you have spoken, so we won't speak much about.
Yeah.
But another thing, I am waiting to hear from Dr. Agarwal what is the latest, because he didn't even tell me what has happened in Wuhan. So I want to listen to it. So this is the story why we should listen. But anyway, the take-home message is the same: suspend initiation, allow urgent fertility preservation, strong consider cancelling embryo transfers, directed oocyte donation when the donor has begun, oocyte stimulation may be continued, suspend all elective surgeries, sample anything known for corona. Next slide, please. And when an urgent procedure must be performed, minimize the time of the patient waiting in the reception area, waiting room, to ensure minimal contact with the patient, to comply with every public health authority recommendation of social distancing, reproductive medicine, and the telehealth model needs to be followed. Each clinic should develop their written emergency plan for tank storage and maintenance. And apart from that, each clinic should have a consent form for any patient who's coming for treatment, for them to understand that in case they get COVID, it is not because of the hospital. Apart from that, minimal staff in the ongoing quality control. Please provide a platform like websites or application or phone calls to allay the anxiety during this difficult time. I wanted to wrap it up fast. And Dr. Agrawal, for the vote of thanks to you, please.
Before he says that, Sunil, can I ask you, can I change my line, my profession?
Great idea. I know.
And you know, there is something how I would like to at the moment say just 2 words now, because सच कहूँ ये भाषा मुझे बड़ी खूबसूरत लगती है, हमारे इलाके की है. तो एक चीज जरूर कहना चाहूंगा, जो कहते थे कि मरने तक की फुर्सत नहीं है, जो कहते थे कि मरने तक की फुर्सत नहीं है, वो आज मरने के डर से फुर्सत में है.
Good one.
घर गुलजार सूने शहर, बस्ती बस्ती में कैद हर हस्ती हो गई, आज फिर जिंदगी महंगी और दौलत सस्ती हो गई. और सर सबसे बढ़िया तो यह है, देखिए सुनिएगा, जरा मुलाहिजा फरमाइएगा, बहुत ही कमाल की चीज है कि किसी के गुजर जाने के बाद शहर बंद होना बहुत बार देखा है. किसी के गुजर जाने के बाद शहर बंद होते कई बार और बहुत बार देखा है, लेकिन कोई गुजरे नहीं, इसलिए शहर को बंद होते पहली बार देखा है.
क्या बात.
तो सर, तो ये एक छोटा सी बात है जो हम सब महसूस कर रहे हैं, और शायद इसी हंसी के दौर में इसको आगे बढ़ाना चाहते हैं. डॉक्टर अग्रवाल, please a vote of thanks from your side, please, sir.
Sure. Thank you very much, Sunil. It is my great pleasure and a distinct honor to convey my vote of thanks on behalf of myself and Sunil to everyone in this panel. I want to say thank you to Dr. Christopher Blockeel, who had to leave just a few minutes ago for another engagement. Dr. Hrishikesh Pai, Dr. Prakash Trivedi,
Next
Dr.
slide, please.
Sudha Prasad.
Sir, could you move to the next slide, please? Next slide, please, sir.
Okay. To Dr. Sudha Prasad, to Dr. Nandita Palshetter, and Colonel Pankaj Talwar. Thank you to each and every one of you for sparing your time and for such a great exchange of information and experience and advice from each and every one of you. That was really, I think, very enriching for all of us as well as for all our audience who have joined. So we are very grateful to you. I also want to convey my personal thanks to our moderator, Dr. Sunil. He is just incomparable. I remember, if you all, I think it's been a long time for young people, probably they will not, but we used to listen to Radio Ceylon, and there was a person called Amin Sayani.
Yeah.
Amin Sayani.
So I think Sunil sometimes reminds me of that personality, and I think he has the right personality to carry this type of conversation. It felt like we are all sitting together.
Yeah.
And there was, despite huge differences, it did not feel the same way. He conducted this meeting superbly and with so much personal touch that we are all very much grateful to him. I also want to thank Mr. Durga Prasad Satpathy from Intas Pharmaceutical for providing unrestricted educational support to this forum, and also to his colleagues, Mr. Sanjeev Kumar and several other team members. There was a whole lot of team people who were engaged in making this effort possible. So we are very, very grateful for all their support and their technical know-how in arranging this type of event. Now I want to ask Dr. Sunil to talk about the next event that we are planning. So Sunil, can you update everyone about this upcoming
What happened about one
webinar?
story?
Yes, it's been a pleasure and it's been a training experience to work with you, Dr. Agarwal. He is so meticulous. He's to the point that for all of this, we actually had a dress rehearsal 3 times. And all these slides were personally edited and cleaned and prepared by him. Thank you very much, sir, for making me learn really how much effort goes into a program. And then this program was planned by Dr. Agarwal, who said that we should have 2 topics. Number 1, the psychological problems during lockdown for doctors as well as for the patients. And the second was the financial problems during and after lockdown, which we probably would face, whether any kind of clinics we are running and what should be planned for it. This is what it is. And it has been planned for 21st of April, again from 6 to 7:30. And next slide, please. Next slide, please.
So this is about the study.
Yeah, the surprise. You can
So,
tell us.
Yes, Dr. Agrawal, please.
Okay, let me just minimize the screen here. Okay, so this is a paper that is under process of just being accepted in fertility and sterility. And I received this paper just yesterday evening or almost night, and I was reading through it, and I found that the results are interesting. It tells a story. I don't think it tells everything that we would like to know at this time, but I think at least the story is encouraging. So this group of scientists or authors, many of them from Wuhan, and they collaborated with some of the American counterpart in terms of putting this study together and publishing their findings in fertility and sterility. So if you look at what was done here, this is the main objective of the study was to detect the presence of SARS-CoV-2 in semen of patients who are recovering for the infection, and to evaluate the expression profile of 2 proteins, ACE2 and TMPRSS2, within the human testis, and to try to find what is the mechanism of how it enters into the testis. It is an observational cross-sectional study with 34 patients who were diagnosed with COVID, and they were confirmed by qRT-PCR. And the expression profile was tested using single-cell transcriptomic analysis, and the cells using these 2 proteins. And these are the main results. I tried to summarize it in 2-3 slides. 6 patients demonstrated scrotal discomfort concerning viral orchitis, which is also seen with some other type of viral infections. So this is nothing very special. But if you look at the table on the right, you will see all 34 patients and have been tested completely negative. So after a median of 31 days, there was no COVID virus was detected. The diagnosis of COVID was completely negative in these positive patients. And the expression profile of these proteins were measured, as I said, by qRT-PCR, and there was really on the right side, if you look at, there is no expression of these 2 proteins on the right side in the testis of these patients. So what the authors have tried to summarize is that the SARS-CoV-2 infection was absent in semen of adult Chinese men who are recovering from COVID-19 approximately a month after the initial infection was confirmed. However, they do caution the readers to rule out the presence of SARS-CoV-2 in the seminal fluid during an inactive acute infection with severe COVID-19 symptoms. So I believe that the news is somewhat encouraging. The ACE2 mediated viral entry into the target host cell is unlikely to occur within human testis based on these two proteins. But at this time, the authors are not ready to say what may be the long-term effects of this virus infection on male reproductive function. So this is the main message here that I wanted to convey. Obviously, we have many more things that need to be studied. And we probably know very little about the infection at this time and its repercussion on our reproductive system. So,
Doctor, sorry.
Yes, go ahead.
Thank you very much. It's very illuminating. Probably Dr. Ashok and I myself sat down with some documents which we would like to give to you. One of them is, of course, this presentation. And sir, I think the link is in the other presentation. We opened the present. Yes, it's over here, sir. So we have over here, apart from this presentation, the guidelines for functioning of clinics, small hospitals and medium hospitals. These guidelines have been found by the IMA Hospital Board of India. So these are something which would be very useful. We have 2 consent forms for any patient with a self-declaration and special COVID-19 consent. One of them is in English and the other we have formed in Hindi. This probably could be formed in our own this thing. There is also a consent of suggested protocols for surgeons of COVID-19, which is by Dr. Shiv K. Mishra, who has also been our ASI president before this. And the Ophthalmological Society has come up with a consent of pandemic emergency ophthalmic treatment. So any emergency treatment which may take place would probably, sir, it was fine. So please, on the end of it, we have this presentation with all these consent forms. Sir, could you go to the last slide, please? Last slide, please.
Yeah, I'm trying to. I think I don't know how I messed up.
No problem. So that last slide has a link. The website is under construction, so we could not leave a link there. So this is a temporary link which we have left for about 24 hours or 48 hours, the way it has been formed. You'll have to, yes, that's it. You'll have to visit my Instagram profile and you'll be able to get it from the bio over there. So this is the link which is there, and it's an active link for you to get all these consent forms which are there. So I think it has been really a fantastic meeting. Dr. Sudha Prasad, Dr. Prakash Trivedi, Madam Nandita, Dr. Hrishikesh Pai, Dr. Pankaj Talwar, Dr. Blockeel, who's not here, and on top of that, Dr. Ashok Agrawal. My God, you have been amazing. And you all have been amazing, but most important, the audience which is there with us, you have been amazing to spend 2 full hours on COVID just to know what can you do better for your patient.
Thank you. Thank you so much.
Thank you very much.
Thank you
so much.
Thank
you so much. Sir, could you please leave the last slide, please? No, this.
Bye, everybody. Well enjoyed. Thank you.
I actually forgot to mention something, Sunil, so I thought it would be appropriate, otherwise, that
right,
which Prakash Trivedi had already mentioned in passing, that our own Dr. Deepak Modi has done some work where he has shown the COVID receptors, ACE2 receptors on the epiblast cells of the blastocyst, but not in the early stages of the, like till the day 3 embryos, they are not expressed. So he had done an RNA sequencing, and it's a lovely paper which I forgot to mention about it in this discussion, but it has done a good landmark research work.
Yeah, that and there is a very good book on Corona. So I think so all of us should go through.
So our next meeting, as Dr. Agarwal has pointed out, is on the 21st of April. So we would love all of you to be there on the 20th. So the slide of the 21st of April, please, if it's there.
Oh, thank you.
Thank you.
Sir, thank you very much, sir. I'm really having to bother you, but I think very few people can take up the job which you have taken. Thank you very much, sir.
Thank you.
Thank you.
Thank you
This is
very
the
much.
next program,
Thank you.
and hope you could be there. Thank you very much.
Thank
And
you.
bidding goodbye to everybody. You have been a wonderful audience. Thank you very much.
Thank
Thank
you.
you.
Thank you, sir.
Thank you.
Thank you, sir.
Should we,
Thank you.
And sir, let me be honest now.
Sanjeev,
My
you
God.
can you mute so that the only the speakers can talk? Or Durga, can we mute the audience?
Prasad.
Or we can